partial or full thickness rotator cuff tears, as well as and including biceps pathology. So the extrinsic theory is really that mechanical impingement or friction of the outlet itself onto the rotator cuff causes this issue. And Meyer in 1922 suggested that the contact between the greater tuberosity and the acromion was a cause for rotator cuff damage. And then later, Codman in 1932 suggested and elaborated that the process may be multifactorial and some sort of trauma or insult is needed to start this vicious cycle of inflammation that ultimately leads to tendon degeneration and tearing. And finally, Neer in 1972 described this chronic impingement theory, and that's what we have pictured here in this classic article. In this instance, impingement he defined on the tendinous portion of the rotator cuff by the coracoacromial ligament and the anterior 1/3 of the acromion, suggesting it's responsible for this characteristic syndrome of disability in the shoulder. The treatment of impingement was to remove the anterior edge and undersurface of the anterior part of the acromion. And he had several stages from edema, hemorrhage to fibrosis, tendinitis, and bone spurs and tendon rupture. So ultimately, others have suggested, my senior colleague, Dr. McFarland, and others, that maybe it's perhaps more appropriate to suggest that rotator cuffs are really associated with certain acromial morphologies and spurring, but studies have not shown causation. And impingement should really be better referred to as rotator cuff disease because that more accurately reflects the multifactorial nature of this problem. Intrinsic degeneration, on the other hand, of the tendon with age has also been shown to be a causative factor. So classic impingement syndrome or pain might be better referenced as anterolateral shoulder pain because of the variety of etiologies of pain in that region. So the intrinsic theory suggests that this degeneration causes some traumatic issue, leading to a weak supraspinatus that's unable to keep the head centered, extending to humeral head migration or abutment of the head against the acromion, which ultimately then leads to this acromial spur. So where is the truth? This rotator cuff pathology is likely a combination of both intrinsic and extrinsic factors, and each patient likely has a different amount of contribution of these factors and reflecting their genetics, their scapular morphology, and other environmental factors. So what other anatomic characteristics play a role? We know the Bigliani classification suggested flat, curved, or hooked types of acromions, but the evidence is a bit mixed with respect to their outcomes and their correlation. Ultrasound studies showing a high association with type 3 population, but there's poor inter-observer reliability when classifying type, as suggested by several other studies. So as we look at magnetic resonance imaging of these different types of morphologies of the acromion, this study out of South Korea looked at 29 patients with this hooked type, and ultimately there was no difference in ASCS scores or constant scores in the hooked group, although the constant score was slightly lower, but not greater than the MCID. Acromial enthesopathy and rotator cuff tears have also been looked at in a cadaveric study, and they found no correlation between degenerative changes on the undersurface of the acromion and rotator cuff tears. And with 34 of 36 cadavers with partial cuff tears were really articular-sided, regardless of the spurring. So they thought more likely an intrinsic pattern. So the conclusion so far suggests the spur might be a consequence of the cuff dysfunction and not the cause, and the shape of the acromion may not be as important. So there's no agreement on classifying it anyway. So there has to be other factors. Rotator cuff is the only tendon in the body that is covered by bone, the acromion, and also is disproportionately torn. So if we consider the quadriceps rupture rate of 1.3%, patellar tendon less than 0.5%, triceps less than 2%, Achilles rupture even less likely at 5 in 100,000 people every year for an incidence. So population studies of rotator cuff tears, on the other hand, 8 to 23%, which is really high. So there must be something to do with this acromion and scapular morphology, but we're still figuring out what. So there have been many anatomic and evolutionary type studies suggesting the coracoglenoid angle may be different, or the size of the supraspinatus and the supraspinatus fossa have changed over time as we've evolved. So in an evolutionary sense, this study suggests that alterations in this morphology may not be responsible for some of the high numbers of cuff tears. However, other studies looking at different species from chimpanzee here on the left to Homo sapiens on the right show this variation in acromial coverage. So a larger deltoid, a wider acromion, and smaller supraspinatus can lead to increased superiorly directed forces, and that may have something to do with it. So we come up with these more modern evaluations of this coverage of the humeral head under the acromion, the acromial humeral index, and then more recently, as proposed by Gerber, the critical shoulder angle that takes into account glenoid inclination as well as lateral acromial overhang. And however, the position of the humeral head relative to the acromion was discussed prior to these concepts, and it's really the percent of humeral head coverage of the acromion. And they did find a correlation with rotator cuff tears. When you have greater coverage, a greater percent of the humeral head under the acromion, a much higher likelihood of a tear compared to less coverage. And we see these variations in pathology. A greater CSA correlates with cuff tears as the force vector is directed upward versus our osteoarthritis with the force vector directed more medially, as you can demonstrate here. So does scapular morphology affect the integrity of the rotator cuff? The studies are mixed, and it is quite confusing. This study by Pandey et al. Suggested there was no association with Bigliani type, and the acromial index and CSA were significantly different between the two groups. So the CSA and acromial index likely play an important role in patients that progress to full thickness tears and develop spurs. But again, causation is not clear. What about the clinical studies? So there aren't a great deal of studies, but this is a 2-year randomized control trial of 134 patients with exercises versus subacromial decompression. So both groups had significant improvement at 24 months, and there was no difference in the large majority of the outcome scores and pain. However, the subacromial decompression group did have quicker improvements, but also costed more money. And another multi-center trial with 3 groups, subacromial decompression, diagnostic scope, and no treatment, with only 6-month follow-up in the Oxford Shoulder Score, all groups were found to have improved with no difference between groups. However, if you look at the treatment assignments, many of them were did not remain in their assigned treatment group, so it makes it very difficult to interpret these studies. So is shoulder impingement syndrome and subacromial decompression, and it did not differ from diagnostic arthroscopy for shoulder pain at 24 months in this study published in 2018. So secondary analysis compared decompression to PT only, and it did do better, but not more than the minimal clinical important difference of 15. So in another study comparing subacromial decompression to therapy alone, again, no difference in cuff tears on ultrasound, but trended towards more tears in the PT group, which is concerning. Another trial, 2-year follow-up by Verma's group, looking at the use of subacromial decompression in the setting of arthroscopic repair. That's a little bit different question than what we're asked to evaluate with impingement. However, I think it's important when you look at the subgroup analysis, there was starting to be a trend towards significant re-tear rates higher in the group that did not get the acromioplasty. And another recent study showing post-op MRIs at 2 years showed no difference in morphology between healed and unhealed tears. So there's a lot of confusion about these angles and clinical results after. And the real question, what we're trying to get at, is can we surgically modify any morphologic characteristics? And we're only starting to get at this. Millet started to look at a cadaveric study showing it was possible without deltoid dehiscence to narrow that angle and decrease the humeral head coverage. And Gerber's study, this case series is interesting as it looked at 49 patients, and the actual clinical effect of a critical shoulder angle reduction showing that the post-op CSA is significantly larger in repairs that failed. So there was some benefit, and there is some intrigue here that this decompression can modify the natural history afterwards through surgical decompression. So this study is a radiographic follow-up of Dr. Verma's study long-term that didn't find any differences in CSA. So in conclusion, the recent clinical studies have concluded that acromioplasty does not offer many benefits, or it's mixed, but we have to keep in mind these studies are underpowered with short follow-up, with mixed interventions that people have transferred groups that they were assigned to even in the randomized trial. So the results are very difficult to interpret, and they tend to the null hypothesis, meaning that all groups are similar. So the beneficial effects of the decompression are likely much more important over long periods of time, over lifetimes, decades, and we just don't have that kind of research available to us. But a well-done subacromial decompression is still an important part of the surgical treatment armamentarium that we have, in my opinion. And I think it's important to consider these factors, and they may, when we're still figuring out how to apply them to each individual patient. It's still a relatively novel concept about what aspects of scapular morphology are important. So what to do? The goals are obviously still remain to remove pain generators, remove extrinsic bone compression, bursa, the coracoacromial ligament. Maybe it promotes some additional biology when we're doing rotator cuff repair, the bleeding. Maybe there's some placebo effect and forced rehab. Patients are forced into this regimented rehab after surgery. While the evidence is low, it's very difficult to get high quality evidence. It is intriguing in my mind that the natural history over long terms does suggest some influence of the subacromial spurs. And I think the risk is quite low to do this. So I think the harm is low and limited. So in my opinion, there is still a role. We just still have to figure out exactly what that is. Thank you for your time.
Thank you very much, Professor Sirik Omaran, for this great lecture. Now we are going to have Professor Dr. Bassel Liga from GOP Shoulder Hospital, Bonn, Germany, and the president of EGSSA, discussing with us the evolution of treatment of subacromial pathology.
You see the presentation?
No, we didn't.
Yes, I have it, but the presentation is not there. In my lab, in my okay, I opened the presentation. Where is that? Desktop or screen? You have it now? Okay. Okay, good evening. I will talk about evolution of the treatment of subacromial pathology. A quick review. The first description of rotator cuff tear was done in 1834 by Smith. And in 1867, Yarabai was the first to observe a morbid process in the subacromial bursa, who, on the basis of a few cases, gave general description of subacromial bursitis. Play in 1872 introduced the term periarthritis humeri scapularis, which is stiffness and pain, and he referred the cause to subacromial and subdeltoid bursa. In 1942, Peterson published observations on subacromial pathology. In the late 30s then, Armstrong recognized impingement as a source of shoulder pain. It was thought to be against the lateral acromion. Complete acrominectomy procedure was recommended from Watson, Jones, Armstrong, and Hamann. The resection of the lateral three-fourths of the resection of the lateral three-fourths of the acromion was then suggested by Smith-Peterson in 1943. Then resection of the lateral one-third of the acromion was then suggested by McLaughlin in 44. So, general acrominectomy, all acromion resection procedures led to deltoid weakness, wound complication, and functional impairment. Some in 62 have suggested to shift the glenohumeral joint downwards by making a glenoid osteotomy so that to be away from the acromion to relieve impingement. Transacromial approach was described by Dubert to treat cuff tear without damaging the deltoid. It did not relieve impingement. In 1972, Neal described the impingement syndrome as extrinsic stenosis or compression of the space through which the supraspinatus tendon passes. And he advocated as extrinsic factors. And he described that impingement is comparison of the soft tissue against the anterior one-third of the acromion on shoulder elevation above 90 degrees in the arc of function. And he postulated that 95% of rotator cuff tears are due to outlet impingement. The supraspinatus outlet narrowing is due to anterior acromion spur causing impingement, as he stated. Supraspinatus outlet narrowing also can happen through increased slope of the acromion or AC joints osteophytes. Then in 1984, Bigliani presented a relation between the shape of the acromion and subacromial narrowing, and he divided that into three types: flat, curved, or hooked, which is mainly or mostly in hooked acromion. Now, in 1983, Neal presented his procedure of anterior acromioplasty to remove bone from the anterior acromion in order to establish a tunnel and free the rotator cuff from impingement. And the anterior acromioplasty was done through a wedge resection of the anterior acromion and the removing of the spurs from the acromioclavicular joint if present. And in case of a symptomatic AC joint, he will do a resection of the lateral end of the clavicle. In 85, the man presented the arthroscopic subacromial decompression by removing a wedge resection from a bone from the anterior acromion arthroscopically in order to widen the subacromial space. And other causes of impingement were described as loss of the suspensory mechanism in case of dislocation of the AC joint or a dynamic narrowing of the subacromial space. Variation of the cause of impingement syndrome and technique modification of the subacromial decompression is very important, and caution in the diagnosis of the impingement are recommended, as we will be seeing in this webinar. Thank you very much.
Thank you, Dr. Bassem, for the greatest presentation. Now we are going to have the indication and the limitation of subacromial decompression, and it will be presented by Professor Dr. Mohammed Youssef, MD, EGSSA Shoulder Hospital, Bonn, Germany. Please start, Professor Mohammed Youssef.
Good evening, dear colleagues. My name is Mohammed Youssef. I'm a consultant orthopedic surgeon in Herford, Germany. I would like to talk about the indication and limitation of the subacromial impingement syndrome. By the way, I like to call it subacromial impingement syndrome and not impingement syndrome, because there is another impingement in the ankle joint and hip joint. Okay. The subacromial impingement syndrome is the most common disorder of the shoulder, resulting in functional loss and disability in the patient that it affects. Neer divided the impingement syndrome into 3 stages. Stage 1, edema and hemorrhage usually occur in the patient below 25. Stage 2, fibrosis and tendinitis with a typical age of 25 to 40. Stage 3, bone spurs and tendon rupture in patients above 40. Causes of subacromial impingement syndrome: intrinsic mechanism and intrinsic mechanism, muscle weakness, repetitive microtrauma, degenerative changes of the acromion, extrinsic mechanism, shape and gradient of the acromion, scapular, muscular paralysis. Classification of pathomechanics of impingement syndrome: outlet impingement and non-outlet impingement. The outlet impingement is anterior acromial spore, shape of the acromion, slope of the acromion, prominent at the joint. Non-outlet impingement: prominent greater tuberosity, loss of the head depressor, loss of the glenohumeral fulcrum, loss of suspensory mechanism, defect of the acromion, thickened of the bursa or cuff, loss of the lower extremities, abnormal use. So treatment option and indication: as usual, the goal of treatment is eliminate the pain and restore the joint function. Conservative treatment: in absence of the major damage, conservative multimodal treatment for 3 to 6 months is the initial therapy of choice. The anti-inflammatory: regular administration of the anti-inflammatory drugs for 1 to 2 weeks to reduce the pain. Physical therapy: mobility of the joint should be gradually increased, loosening, massage, and physical measures, including heat or cold application, electrotherapy as iontophoresis, and exercise pools. Corticosteroids injection, very important to improve the mobility and reduce the pain. Shock waves therapy is used to treat calcific tendinitis. High energy shock waves lead to the disintegration of the calcifications. Exercise: once the acute pain has been treated, emphasis is placed on the physiotherapeutic measures for mobilization. Approximately 30% of the patient undergo surgery. After ineffective conservative treatment, surgery is indicated after 3 or more months of the conservative treatment. So, subacromial decompression that involves removal of the anterior and lateral portion of the undersurface of the acromion, 5 to 8 millimeter, and detach of the coracoacromial ligament. Neer published the Anterior Acromioplasty procedure. as a treatment for impingement syndrome by making a wedge resection of the anterior acromion and upper third of the coracoacromial ligament. He indicated that the surgery is done only in the case of failed conservative treatment for a period of 1 year and having a positive impingement tests. Ellman, 85, described the technique of the arthroscopic subacromial decompression by using an acromionizer to resect the anterior acromion protuberance and the osteophyte to achieve a larger subacromial space. The position of surgery was in a lateral position on the page chair or sitting position, of course. So the indication of anterior acromioplasty, outlet impingement, according to Neer, 83, when repairing an impingement tear, more than 1 year, pain with conservative therapy, occasionally stage 2 with acromion. Non-outlet impingement, greater tuberosity, malunion. Arthroscopic guidelines modification by Ellman if the space less than 12 mm, more than 6 months for second stage impingement, positive bone protuberance and spore with stage 2 protuberance bone, and for the arthroscopic non-outlet is only of the if the tuberosity to be below the head level. So I would like to show you the video here. We can see the acromion and of course the supraspinatus tendon with coracoacromial ligament. Here we can see also the bone spore and friction between the bone spore caudal to the acromion, and we are going under the acromion spore with acromionizer, dissect the bone spore to achieve a place between the acromion and supraspinatus tendon. Okay. I would like to show some picture for Professor Neer and his open arthroplasty, acromion protrusion, and also Ellman for the arthroscopic lateral decubitus position and semi-sitting position, and also the sitting position. So the controversies, both open and arthroscopic subacromial decompression outcome are consistently reported very good results. Different recommendation of when to do surgery are present in the literature, either following non-operative treatment for at least 6 weeks, 3 months, or 6 months, or 1 year also. Some recommended that decompression should be done with all rotator cuff tears. Others did not recommend that at all, as a recent study suggests. How to deal with the coracoacromial ligament? Complete resection, partial resection, or non-resection. Controversy is doing subacromial decompression in a case of calcium, workers, compensation, and partial rotator cuff tear. Yes or no? Question mark. The acromion shape. Okay, here the acromion shape, I would like to show the difference between the flat, curved, and hooked acromion, and also between the coracoacromial ligament. Here are also the space between the acromion and the tendons, and acromion and humerus bone. An arthroscopic and radiological study was done on 410 cases who underwent a subacromial arthroscopic surgery in the shoulder hospital bone. An arthroscopic evaluation of the space between the anterior acromion and the rotator cuff, the AAC space, and the radiological assessment of the shape of the acromion and the space between the anterior acromion and the head, called the AH space, was done. Classification of the space between the anterior acromion and the rotator cuff supraspinatus tendon, C space: 133 impingement tier, 156 impingement stage 2, calcification with 97, instability impingement 24. The purpose of the study was to assess the relation between the rotator cuff tier and the shape of the acromion, the size of the radiological anterior acromial space, the size of the anterior acromial cuff space, and the relation between the shape of the acromion and the AAC space, and the relation between the radiological anterior acromial humeral space, AHA space, and the AA space. The arthroscopic study is done with a patient in sitting position and the arm hanging as a standard for measuring the AAC space, and by using two measuring needles, one placed on the medial and one in the lateral corner of the anterior acromion for space measurement. The space between the anterior acromion and the rotator cuff AAC space was classified to 4 types. Type 0, where the space is more than 12 mm, type 1 with a space between 6 and 12 mm, type 2 between 1 and 6 mm, and type 3 less than 1 mm. So the evaluation of the relation of the space measurement to the pathology showed that in type 0 with a space of more than 12 mm, there was mainly instability impingement cases where the narrowing is only dynamic. An outlet impingement, rotator cuff tear, and impingement stage 2 was not found in the type 0, but mostly type 2 and 3. So, based on this study, there was almost no outlet impingement pathology when the space was more than 12 mm or type 0 AA space. Analysis of the 133 cases of rotator cuff tear showed an average radiological AH space 7.9 mm, an average AAC space 6 mm. A spore formation on the anterior acromion was present in 17 cases, a flat acromion in 28%, curved in 38%, and hooked in 34%. Comparing the recommendation done in the era of open decompression and the rotator cuff repair to the arthroscopic possibility of treating impingement, nowadays we can present the following based on the measuring needle technique knowledge. So in repairing rotator cuff tear, decompression is only done when the space less than 12 mm, not for all cases. So our experience showed that 6 months of failed conservative treatment with the modern physiotherapy for impingement syndrome without cuff tear is an indication for arthroscopic decompression, and not 6 weeks or 12 months. All other causes of non-outlet impingement are only treated with arthroscopic decompression when the AAC space measures less than 12 mm after treating the non-outlet impingement cause as removal of the calcium or treating a greater tuberosity pathology. Take-home message: in case of outlet impingement, decompression is only done when the subacromial narrowing is less than 12 millimeter. In case of non-outlet impingement, read first inferior cause narrowing the measure the space to see if the subacromial decompression is indicated if the space less than 12 millimeter. Thank you very much. Thank you for your attention and sorry for extension.
Thank you, Professor Muhammad Yusuf, for the nice presentation. Now we are going to have Professor Dr. Sharif Al-Ghamri showing us impingement syndrome and rotator cuff tear.
I will stop sharing and screen. No? I didn't find it. This is the problem I told you. من عندك بقى. Okay, hi everybody. I'm Dr. Sharif Al-Ghamri. I'm a consultant orthopedic surgery. And I can see that we have more than 200 participants today. So I would like all of you to, I will encourage you to visit our website. And who is interested, he may apply also to our membership. Next. Today I will highlight the relation between rotator cuff tear and impingement syndrome with its most common problems and variations. Next. The factors causing rotator cuff degenerative tear are mainly, no, the previous one. Extrinsic factors causing extrinsic compression as acromial spurs or downsloping of the acromion, or they are due to intrinsic factors as degenerative microtrauma. Next. Neer classified the rotator cuff tears into traumatic tears, acute dislocation, multidirectional instability, and impingement tears, in which the impingement tears makes 95% of all. He stated that glenohumeral joint destruction with loss of the fulcrum action after old large tear can lead to rotator cuff tear arthropathy and superior migration of the head causing impingements. Next. The incidence of the types of rotator cuff tear based on 1,000 evaluated cases in our hospitals showed the presence of traumatic tear is only 7%, mostly due to fall on the outstretched hand, and multidirectional instability tears or partial tears in 2% of the cases, while the outlet impingement tears were present in 91%. Next. The anterior acromioplasty procedure for treatment of outlet impingement rotator cuff tear was described by Neer in 1983, and the repair of the tendons was done using the either simple and or a Mattis transosseous sutures. Next. Later, the anterior acromioplasty was done arthroscopically. Next. Modification was done by a measuring needle technique to measure the subacromial space and monitor the decompression using surgical standards and calculated decompression targets. Next. The rotator cuff tear was arthroscopic or subacromial decompression is done using suture anchors, mainly single row or double row techniques. Next. Or arthroscopic transosseous rotator cuff repair, mainly using the giant needle technique. Next. And the tailor stitch arthroscopic transosseous rotator cuff repair. Next. The considerations for arthroscopic subacromial decompression before doing the rotator cuff repair. Next. Do we total, partial, or no resection of the coracohumeral ligament with a rotator cuff tear? This are the considerations. The controversies of the intervention range from recommendation of resection of the upper 1/3 of the ligament to complete removal or only detaching the ligament from the acromion. And some recommend no intervention in general or only in cases of massive rotator cuff tears. We monitored during arthroscopic decompression that by cutting or detaching the ligament from its acromial insertion at the subacromial space will increase 2 to 3 millimeters. And we observed in most decompression revision cases that the ligament is grown again to anterior acromion. So we described that as an indirect lengthening of the ligament. Next. In cases of frozen shoulder, superior subluxation may be present due to intra-articular adhesions. So the considerations are taken to first release the adhesions from the glenohumeral joint, then evaluate the subacromial space to determine the amount of bone to be resected from the anterior acromion for decompression if needed. Next. The large old rotator cuff tears may cause superior subluxation with intra-articular adhesion. In treating these cases, considerations has to be made to release the adhesions and mobilize the rotator cuff, then do a tendon complete or partial repair, and finally measure or evaluate the space for subacromial decompression. If no repair can be made and reverse total shoulder is not possible, so you do subacromial decompression anyway in order to minimize the head contacting the acromion, which may cause the pain, and also to lessen the possibility of arthropathy complications. Next. Calcium deposits in the supraspinatus tendon can lead to thickening of the tendon and narrowing of the subacromial space, causing impingement, which may need arthroscopic intervention. So consideration has to be made to do arthroscopic calcium removal with or without repair. Then measure or evaluate the subacromial space and do decompression only if still have a narrowing. Next. Prominent greater tuberosity causing impingement in Erb's palsy is treated by arthroscopic resection of the supraspinatus tendon from its insertion on the greater tuberosity, followed by removing of the head overriding bone from the tuberosity with an acrominizer. Then reinsert the tendon using transosseous sutures. A subacromial decompression is done if needed. Next. In case of prominent greater tuberosity due to malunited or non-united tuberosity fracture, malunited surgical neck fracture, and in case of low head implantation. Treatment is done by arthroscopic resection of the supraspinatus from the acromion and removal of the head overriding bone, followed by transosseous reinsertion of the tendon and subacromial decompression if the space between the anterior acromion and the tendon is less than 12 millimeter. Next. Instability impingement dynamic superior migration due to contraction of the deltoid can cause a narrowing and impingement. Here, treatment is done by first stabilizing the glenohumeral joint through the inferior capsular shift or other arthroscopic similar procedures, followed by measuring the subacromial space to do a decompression anterior acromioplasty if needed. Next. Is subacromial decompression indicated to relieve pain in massive irreparable rotator cuff tears? Rookwood suggested that the decompression is the only treatment needed for all types of rotator cuff tears, but functional problems and some movement pain were the disadvantages recorded. Whether Neer proposed the open decompression as a pain-reducing procedure for irreparable massive rotator cuff tears. Reverse total shoulder is now the treatment of choice for irreparable rotator cuff tears, but patients refusing reverse total shoulder are offered the arthroscopic subacromial decompression as a possible pain relieving option. Next. The take-home message is a thorough investigation should be made to localize the real cause of impingement, especially in non-outlet impingement. Arthroscopic measurement of the space between the anterior acromion and the rotator cuff has to be made. In cases of outlet impingement tear, the repair of the torn rotator cuff is done after arthroscopic subacromial decompression. In case of non-outlet impingement, first treat the inferior or other causes of subacromial space, narrowing before doing an anterior acromioplasty. Thank you very much.
Thank you very much, Dr. Sharif El-Ghamri, for this nice presentation. Now we'd like to have Professor Dr. Philip Valenti discussing with us cuff repair versus subacromial decompression in patients more than 70 years old. Please start, Dr. Philip.
Thank you, sir, for your invitation. I will share my, do you see my, is it okay for you?
Yes, it's okay.
It's okay, you?
Yes, we see it.
Thank you for your invitation. Regarding this subject is not very clear in the literature. So this is, you know that the natural history of the cuff that the rate of rupture increases with the age. And you know that after 80-year-old, you have the risk of 80% of rupture of the supraspinatus. And many people have no pain and they don't know what happens. So now in our society, when you are 70 years old, you are not old. You are a young person and you increase functional demands. If you repair the cuff and if you read the literature, the rate of healing tendon decrease, but the functional result is very nice. If you do a decompression alone, it's very nice for the pain, but it's better if the patient is not active with massive posterior superior cuff tear. And we know that with the long follow-up, after 5 years follow-up, you have a deterioration of the shoulder. So the key question in this presentation in all the patients more than 70 years old is when you decide to repair and when you decide to do acromioplasty alone. If you read the literature, if you repair, this is a valid indication in terms of clinical result and in terms of healing the tendon to the bone. If you do a decompression alone, could be an acceptable decompression, is a lighter option, and I do sometimes. This is a work that I did a long time ago in 2013. And we collect in France, in many centers, in Paris, in Rennes, Bordeaux, and Nice. and we collect 133 patients with more than 1 year follow-up. And we did, it was a prospective randomized multi-center study, and we did 70 repair versus 73 decompression. And we published this article on orthopedic traumatology surgical research. So we include patients with more than 70 years old, full thickness tear of the supraspinatus, extension to the upper third of the infraspinatus. The retraction was less than 2 centimeters, and muscle fatty infiltration was less 3. We excluded patients with 70 years old, but after traumatic tear, when the tendon was healthy, or sometimes with degenerative tendon, but with a good muscle, no infiltration. And I think that in this case, we see the excellent indication of repair, if even the patient is 80 years old. We excluded also massive posterior superior cuff tear of suprainfraspinatus. It was not repairable, was not good muscle with more to fatty infiltration, and we did decompression. In this two type of situation, it's very clear that there is no discussion between repair and decompression. So when we did arthroscopic procedure, we did acromioplasty, bursectomy, we cutted the AC ligament, or if you decide to repair with 1 or 2 rows with acromioplasty. Systematically, we did biceps tenodesis or tenotomy, and we put a sling for 4-6 weeks, and we start immediately passive range of motion. So more interesting, you see that it's a 70 patient with decompression, 70 patient with repair. And you see that both techniques are efficient for patient because preoperatively the global constant score was 41 and after decompression is 73. If you do repair is 80, but it's not significant difference. This is a weighted constant score. You see before repair 59, after repair 100. American shoulder and elbow score, you see that. This is the same increase. There is no significant difference, and we know that the decompression versus repair is a efficient technique. If you repair is better on clinical score. You see that? You do decompression 73. You do repair 80. You do decompression 83. You do repair 93. I think that if you repair in the situation when you are a rupture of the supraspinatus, good muscle, and it's good results. Repair is better on each constant score. You see that the pain is better if you repair, range of motion is better, activities and strength. More important that, and this is a message that if you repair the cuff and you obtain a good healing, you restore a good strength. And if the patient is active, even 75 years old, I think that is younger in our society. If you have more strength, this is a good justification of repair. Regarding the retraction, there is a difference is more significant between repair and decompression for larger tear, especially for pain and strength. If you have a larger tear, type 2 or type 3, if you repair, you can obtain a better result that decompression. And you see that is very important in grade 2. You see the difference? It's 9 points in terms of constant score on assess score. And the recommendation is to recover strength and to relieve pain in large tear you have to do. More interesting, but is logical. If you have a fatty infiltration greater in lower stages of infiltration, you can restore lower strength after repair. You see that it's grade 0, 1 in terms of infiltration. And you compare that grade 2 or 3, you see that you restore a good constant score, but is less if there is a fatty infiltration. But we have to repair, and there is still a difference between decompression and repair. It's very interesting that if you push the indication to repair, even the patient is more than 75 years old, repair remains significantly better than decompression. And if you have a patient of 80 years old with a small tear on good muscle and there is very active, I recommend to repair the cuff. More interesting, with the French Society, Arthroscopic Society, we divided in 4 types of patient. Patient sedentary, patient fairly active, 1 or 2 is not very active, but some patients are very active and they continue to do sports or daily activity. And it's very interesting. You see that for sedentary, you see that if you repair the cuff, it's 76. If you have a guy very active, bicycle, for example, or walking every day, and you can obtain 83 if you repair the cuff. And I think that your indications, that depends only of the status of the cuff, but depends of the patient, on the motivation of the patient to recover a good strength. My first conclusion is even you do decompression or repair, you improve the patient, particularly for the pain relief. And the score is good after 1 year, but you know that the results, there is a deterioration after 5 years. Repair is more efficient than decompression in terms of score, constant score, American shoulder on simple shoulder test, and especially for the strength, but also, of course, for the pain. The difference between repair and decompression is greater when the tear is larger and when the fatty infiltration is lower. And it's very important because fatty infiltration doesn't increase systematically. If you have fatty infiltration of 3 or 4 Goutallier stage, you cannot recover a good muscle. And I think that this is an indication of decompression. And the last point is that the benefit of repair doesn't decrease over 75 years old. And my last conclusion is you have to choose your indication, depends on the patient, and you have to discuss with the patient. What is his activity, daily activity, sports? Because if he doesn't do any sports and he doesn't want to move a lot, you can do decompression. If he does do sports, bicycle, walking every day, we recommend repair for cuff tear. Thank you for your attention, my friends.
Thank you, Professor Dr. Philip Valenti, for this interesting comparison and illustration. Again, we will have Professor Dr. Bassem Plega through failed subacromial decompression, etiology, and treatment.
Hello.
Dr. Bassem.
Okay, I will open from my laptop. So I have opened now. Do you see it? Pardon? Okay. I did share screen. Okay. Now you see it?
Oh, got it, yeah.
Okay. Sorry. Okay, thank you very much. I want to say I will be in a couple of months 70, so the presentation of Philip actually give me a good expectation for the future. I will talk about failed subacromial decompression, the etiology, and the treatment. First, this is the technique we use for subacromial decompression. We use the so-called measuring needle to measure the subacromial space by placing two needles, one in the medial and one in the lateral corner of the anterior acromion. Then we remove the fibrosis and adhesions, and then we cut the ligament from its insertion at the anterior acromion, the coracoacromial ligament, and finally we do the decompression using burr or acromionizer, and then we measure the space after that. The results are mostly good results, especially as you see on the left, the space is about 1 millimeter, and after decompression can be up to 14 millimeters. So it relieves the tendon from any compression from above. Now, the causes of failed of anterior acromioplasty are incorrect diagnosis, technical error, mainly too little bone removal, or inadequate rehabilitation, or even unrealistic post-operative expectation, as in athletes. Post-operative complications of anterior acromioplasty are hematoma, rupture of the biceps tendons, acromion fracture, chronic shoulder pain, chronic shoulder stiffness, damage to blood vessels or nerve, and infections, which actually happens in open repair. Now, we developed the etiology, or we classified the etiology of impingement as a guideline for treating the subacromial narrowing into upper causes and causes in the subacromial space itself, and lower causes. The upper causes are mainly from the acromion or the acromioclavicular joint, and the causes in the space are thickened bursa or effect of the coracoid impingement, and the lower causes tendon lesions, instability, or greater tuberosity lesions. Now, what happened if we do too little bone resection? This is actually the most common cause we see in our clinic of failed subacromial decompression by not removing enough bone from the anterior acromion. Also, a wrong bone resection means we have some cases with persistent pain after decompression, because the decompression was done in the middle of the lower surface of the anterior acromion, leaving the prominent present and causing impingement again. Or in cases of AC joint osteoarthritis, we may have a failed revision because of the presence of the spurs in the AC joints, the bone spurs, causing impingement. So the treatment of that is either to remove the spurs in case the AC joint is not symptomatic, the AC joint osteoarthritis, or if it is symptomatic, we resect the lateral end of the clavicle and do an acromioclavicular joint arthroplasty. The anterior acromion protuberance is also one of the causes of failed subacromial decompression, in which the protuberance is not resected, and it stays to make problems on active elevation. So this will need a revision and removal of the protuberance. Now, what about lateral acromion? Also, recently it was talked about in many papers that the lateral acromion is also a cause of impingement. This also happened, but it is not very much cases which we see of that. but we can diagnose that preoperatively from the clinical examination and the X-ray, or from MRI. So in these cases, we have to resect the protuberance in the lateral acromion, and this is also one of the causes of the failed subacromial decompression. Now, in some cases, there is an open acromial epiphysis, and non-union of the epiphysis, mainly the anterior one, which is the periepiphysis, or the middle one, which is the mesometaepiphysis. This non-union, if not dealt with, may lead to a failure of the decompression. In case of a periepiphysis, it will be resected, but in case of the mesometaepiphysis, reconstruction and closure of the epiphysis should be done using K-wires and cerclage, either open or arthroscopically. Now, another problem for failed anterior acromioplasty is after decompression, there may be a gap present if you remove too much bone, a gap between the anterior deltoid and the anterior acromion. And this causes weakness of the anterior deltoid and problems. This has also to be treated by reconstruction of the deltoid and suturing it back to the anterior acromion. So a post-operative fracture of the acromion can happen after a decompression, especially when the decompression is done in the middle of the acromion. Now, in cases of all dislocated AC joint suspensory mechanism, even if we do an anterior acromioplasty, we may have a recurrence because there is a loss of the suspensory ligaments and leading to an increase in slope of the acromion. In this case, reconstruction of the AC joint is indicated. Now, what about the inferior causes or the lower causes of the impingement, which we have to keep in mind in our diagnosis and treatment? And if we not take care of that, it can lead to a failed subacromial decompression. Well, the second most common cause which we face in our clinic is the partial supraspinated tear. That after decompression, the pain persists, and the reason is that the partial tear is not dealt with while doing the decompression. Of course, the treatment, we have to repair this lesion. Calcium and even thickening of the supraspinatus tendon can lead to narrowing of the subacromial space. As we see here, the tendon is bulged superiorly, causing an inferior cause of narrowing of the subacromial space. Here we have to remove the calcium and clean completely from the tendon. And then after that, we have usually a gap in the tendon, which has to be then sutured with the transosseous reconstruction. After doing that, we measure then the subacromial space and we see if the distance is okay or not. If it's still a narrow distance, we do then repeated subacromial decompression. Now, this is a lesion which actually we call it the spoon lesion, which we notice in our clinic that supraspinatus is very loose and elongated, which happens mainly in young people, found it actually in the 20s to 30s. A histological analysis of the tendon showed that there is increase in fibrosis of the tendon compared to a normal tendon. We don't know why is that or what is the reason. We can only hypothesize that it's maybe microtrauma or activity or something else. So here we do also a resection and a transosseous refixation to stabilize the joint and treat the impingement problem. Now, Open rotator cuff interval can also lead to recurrence after decompression because the head is not stable and will go up, causing narrowing of the space. In this case, also we have to do an arthroscopic closure of the open interval. Frozen shoulder, as said also before, it can cause also an impingement, and not dealing with that during the subacromial decompression may lead to failure. We have to release the adhesions and even do the capsulotomy. And then after that, we see if we need to do a subacromial decompression according to the size of the subacromial space. Cases of multi-direction instability or subluxation impingement, here we have also a dynamic narrowing of the subacromial space with elevation of the arm. In this case, we usually do a treatment of the capsule and do an inferior capsular shift to stabilize the joint and prevent the superior migration. Also, a Hagel can lead to an instability, a Hagel lesion. In this case, also we have to repair the Hagel lesion, and even after decompression, we do another revision and do the stabilization or reinsertion of the subscapularis to the humeral head. Prominence of the greater tuberosity can also cause recurrence after decompression. This prominence is either due to malunion or non-union displacement of the greater tuberosity, or even in cases of congenital prominence, as in case of Ehr's palsy. And the treatment here, what we do is an arthroscopic removal of this bony protuberance and reinsertion of the supraspinatus. Now, the causes which are in the space itself are causing narrowing of the subacromial space. We observed here that after the decompression, we find cases in which the supraspinatus tendon sticks to the lower border of the acromion and causing impingement-like problems. Actually, we saw that also even in cases who didn't have a subacromial decompression. This observation led us also then to do an arthroscopy and release the supraspinatus tendon from the acromion. Also, coracoid impingement can cause of failure of subacromial decompression or treatment of impingement, because it can cause also inflammation in the subscapularis and then an impingement similar complaint. Here also, we do arthroscopic resection of the prominence of the coracoid process. Now, bursal classification can also happen in the bursa and cause an impingement problem. And after decompression, remnants of this calcification may persist during the impingement problem. So we have to be very careful and clean all the calcium present in the bursa to prevent failure of the decompression. Now, expectations by some patients are maybe very high after the decompression, especially in athletes. As here we have 100 cases of decompression in athletes, which are mostly done in weightlifters and gym, tennis, handball, and water polo. And these patients, they want to go back quickly to their sport, which may cause failure of the treatment and recurrent bursitis. So it is very important to follow these patients and always have them in contact with the clinic till they are completely relieved and they are ready then to go back to their sport, which actually may take even up to 4 months. So in general, the main causes of the failed acromioplasty in our vision are diagnostic, technical, or false rehabilitation. and the causes may come from incorrect or technical problems from superior causes for acromion or AC joint, or from inferior causes involving the tendon, the greater tuberosity, and instability, or causes in the space itself. Thank you very much for your attention, and we invite you to our annual Congress next October, and we will be happy if you participate in that. Thank you very much.
Thank you, Dr. Basim, very much. Now we have some questions I would like to read for you, our great professors. The first one, how can we measure the distance, the 12 millimeter of the subacromial space? I think we showed this in these lectures. Using the measured annulated needle can do the job. There is another question for Dr. Valenti. I would like to know your opinion about AC complaining.
Yes, I can do an answer regarding AC complaining. I think for me, clinical examination is very important. And the second point is that there is a hyperfixation on MRI. If there is pain in cross-arm position or pain when you push to the joint and you have on the MRI hyperfixation, I do acromioplasty and I do resection of the AC joint. But in my experience is maybe is 5 or 10%. It's not systematically. When I do acromioplasty, I go to the AC joint if I have clinical sign on imaging sign, but not systematically. How do you do, Dr. Basim? How do you do, Dr. Basim?
Hi, fine. How are you?
Fine. What are you doing to the AC joint? You do systematically a resection or you do acromioplasty?
No, I agree with you. Actually, no, I don't do a systematic resection. I usually, it depends if the AC joint is symptomatic, if the patient has pain symptomatic from the AC joint itself, and there is an AC joint osteoarthritis. So in this case only I do a resection. But even if I have an AC joint osteoarthritis and osteophytes going inferiorly, I do just removal of the osteophytes and beveling of the inferior surface. And that's it. I don't do a resection of the AC joint.
Okay.
Another question to Dr. Valenti is how can you do, or how can you know that you have resected enough enough amount of the acromion?
Yes, this is a very difficult question because there is no scientific data to prove that when there is the distance between the acromion and the cuff. This is my experience, but I put my arthroscope laterally and I use my burr from posteriorly to obtain a flat surface. Because I think that the most important is to obtain a flat surface of the acromion. And after I test with the arm in medial rotation. And in medial rotation, if you have no impingement, for me, the resection is enough. But I have no scientific proof that we have to remove 1 centimeter or 2 centimeters. I think that is very complicated to answer to this question. For me, the answer is my practice. I try to eliminate any impingement in medial rotation, sometimes with the acromion, sometimes with the AC ligament, because you see that sometimes AC ligament is very thick, and the impingement is not to the acromion, but to the AC ligament. And this is the anterior. On the second point regarding the lateral part of the acromion, You know that the critical shoulder angle that is very controversial now, because there is a recent study of people from Oslo, and they report a long follow-up, and they didn't find any correlation between the lateral acromion, the critical shoulder angle, and the cuff impingement. And they didn't find any correlation between the rotator cuff tear and the critical shoulder angle. I think that in the future, we have to check that, because I am not sure that lateral acromiotomy is very useful. It's not my experience. But it's a discussion with you. What do you think about critical shoulder angle?
Actually, I also agree with you. There's no, I don't do any lateral, I don't believe lateral impingement, but well, I'm doing decompression now since about 30 years. And I had some cases who after an anterior, after decompression, they had problems. And clinically also, they had the pain on abduction, not in the functional arc. So actually, very rare cases, very, very rare. I mean, maybe I did, all my life, 10 times a revision and resection and beveling, actually, of the lateral acromion, not resection, beveling, to elevate this. And also in some cases of, some of these cases are revision cases. Maybe it is, there was bone debris who did that, I don't know. But anyway, I don't do any lateral acromion decompression.
I would like to talk a big message for the attendees regarding acromioplasty. If you have a rupture of the subscapularis, if you have the rupture of the supraspinatus with anterosuperior tear, acromioplasty is very dangerous. You have to respect the acromion. You have to respect the AC ligament, because if you have a return of the subscapularis, you have a pseudoparetic shoulder. And I think that for me is a big message regarding acromioplasty. Acromioplasty is good for posterior superior cuff tear, but not for anterior superior cuff tear, because it's dramatic for the patient if you have a return of the subscapularis, because you have no anterior fulcrum, you lose the anterior fulcrum, and you have a superior and anterior migration of the head. And after, the only way is a reverse prosthesis. And be careful regarding acromioplasty in young people. If you have a traumatic tear of the subscapularis, repair the subscapularis and don't touch to the acromion. But I think that Basim is agree with that, because this is a very long experience, and we see many patients with after acromioplasty with imbalance of the shoulder, imbalance anteriorly of the shoulder, and take care for young guy. Don't do any acromioplasty. Even there is a hook, because some people have a big linearity too, and there is no impingement. This is another problem. And I think that physiotherapy to push back and down the head is very, very important, because sometimes the morphology of the patient is not good for acromioplasty. Sometimes a woman with anterior shoulder, because a good on the back, on pain on the back, I think that you have to refer to the physiotherapist, but don't do acromioplasty, please.
Another question for Dr. Basim. Please, Dr. Basim, if you did a case, a subacromial decompression, and the patient is still complaining of severe pain after the operation, instead of doing the operation perfectly, would you like to do revision or refer to pain clinic, or what to do?
Well, if a patient has an anterior acromioplasty and after that he's still having pain, so the first thing I do, I look for the reason why is he still having pain. and there are many reasons. Maybe he didn't do his rehabilitation correctly, and maybe there is adhesions in the subacromial space, or maybe there are other causes like inferior causes or superior causes, which I mentioned. So I don't actually refer the patient to a pain clinic because always if you look thoroughly and investigate the case, you will find the reason, and then you deal with the reason. So, for example, there is a partial rotator cuff tear, or there is a prominence of the greater tuberosity for whatever reason. So there must be a reason for that. And I don't remember that I send a patient to a pain clinic. Some patient I send them to psychiatry because they are a little bit irritated about the outcome of the surgery, but actually this is very rare. Another problem actually, which is more in Europe than here in Egypt, that many workers, after the decompressions, they don't want to be better because they lose some financial aids to that, or they want to go to an early pension and stop working. So we have to be very, very careful with assisting that.
I have a question for Dr. Muhammad Yusuf. What about the risk of acromial fracture of the acromion after subacromial decompression? You heard me, Dr. Muhammad? The voice, please.
Do you hear me?
Yes, I hear you.
Yeah, actually, I'm enjoying to hear to my professors here, Dr. Bassem and Dr. Valenti. It's very amazing to hear them. Actually, the fracture of subacromial, or the fracture of subacromial is, we can just minimize this with the measuring and with the measuring cameras. Also, we have to, in the lateral, on the anterior acromion, we have to measure it arthroscopic. So I don't think when we arrive 12 millimeter, I don't think we have to do more. It's fair enough when we 12 millimeter with a measuring needle is very good, I think.
Thank you. Thank you very much. Another question from Hisham Ibrahim. You agree with me selection of an educated patient is mandatory to do a subacromial decompression? Is patient selection is important? Bassem, can you answer me?
You mean selection of the patient before doing the surgery?
Yes.
Well, if you have an indication for a subacromial decompression, and some patients, as I said, you have the impression that they really have other reasons for that, so I'll be careful doing that, of course. There are other social reasons. So only in this case, yes, I'll be careful to select the patient. Yeah.
I think this is all what we have from questions from our attendees. Finally, I would like to thank all our great professors, Dr. Sri Kumaran, Bassem Flega, Dr. Muhammad Yusuf, Dr. Sharif Al-Ghamri, and Dr. Philip Valenti. Thank you all for this terrific webinar.
Thank you.
Thank you.
Thank you, Bassem. Thank you.
there is an announcement about the next 7th EGSSA webinar about the scapulo-clavicular fracture on the 5th of March, 2021. Looking forward to see you again. Thanks a lot.
Thanks.
Dr. Bassem, do you want to add anything?
Thank you. Just I want to also invite all the colleagues to participate in our first annual Congress, which will take place next October. And we have already launched a call for abstracts for this meeting. Thank you. I thank you very much. This is the announcement about this annual meeting. And I also thank Philip for being with us. And I know the very hard situation in Paris now, as my sister is also living there and tell me every day what is going on there. And we have a very nice situation here, actually, in Egypt. I'm happy for that. Thank you again.
Yes, I invited you, Bassem, and all my colleagues in Paris in July because I postponed my meeting, Paris International Shoulder Course, in July. I don't know if it will be possible, but I think that many surgeons receive the vaccine from United States, from everywhere. I don't know if you receive the vaccine, you, in Egypt, but I think that if many doctors receive the vaccine, we can travel again. And it will be my pleasure to go again to Egypt and to visit you and to work with you. I hope so that for the summer it will be better, because in Europe it's very difficult today. With the UK, for example, the frontier is closed. The frontier are closed between UK and Europe, and I think for many people it's very difficult to live today. And they cannot go to Egypt, they cannot go outside France because it's not possible today. And maybe they extend the lockdown, maybe 2 or 3 weeks more. And for your sister, Bassem, it's not so good to visit you.
I know.
Okay, thank you for your invitation. It's always a pleasure to participate with you. Thank you a lot.
Thank you.
Thank you.